And many of the children that we see in the hospital will become adults with epilepsy and also have to contend with these issues. The other important thing is the health economics. So these papers are now probably about 10 years old, but say the same thing. There's one registry study in Sweden looking at the total cost of epilepsy. So as I said, it's the most common serious neurological disorder. It's expensive, but the biggest cost is to do with absenteeism from the workplace. And the biggest reason for absenteeism in the workplace with epilepsy is mental health comorbidities. It's very expensive, and it's the mental health that really causes problems more than the seizures themselves. Both of these studies show the same thing. So there's something there about managing to the mental health issues would be cut down hugely on the cost to society. Some of the other early signals from the literature suggest that there's a few targets for intervention. So study on the left, again, another population study from Scandinavia that Richard Chin in Edinburgh led on. And they were looking at outcomes, health outcomes of people aged 33 with childhood epilepsy onset. And they found two things associated with poor general health and also poor mental health. One of those was having a learning disability, so that's uncontentious. But the other thing was anxiety over acceptance by peers in that peri-adolescent period. So something about as you're entering adolescence, feeling different from others, having a condition that means that you might not be able to access things in the same way, and you're also uncomfortable talking about it, predicted later mental health issues. So we've always thought that was an important signal and something that we should do something about. And just at this point to say also that young people with epilepsy-related mental health issues tend not to have complex, severe mental health problems that would let them access CAMS. They tend to have a lot of anxiety, social isolation, and things that might lead to later more severe psychiatric disorder, but they often don't present with conditions that mean that they can access mental health services at that time. So Anthony did a recent systematic review just to look at the evidence for psychological, psychosocial interventions in childhood epilepsy, and found that there was 4 high-quality studies. One of them was one of our RCTs, and just finding a bit more of an evidence base, because we did this 10 years ago and there were no good quality studies. There's now 4, and using things like CBT, mindfulness, and sort of ACT-type principles have been thought to be effective. Also last year, the NHS England produced a service specification recognising the importance of supporting the mental health care needs of young people with epilepsy, and actually there was a lot of funding available for trusts in England, which is also one of the drivers for us to develop the intervention we're about to speak about. So about 8 years ago, we did an RCT of a group, of a 6-session group-based manual-driven psychological therapy delivered by an epilepsy nurse and a clinical psychologist. And they grew from, we did focus groups. The focus groups actually were about 15 years ago. We asked young people themselves what were their concerns around growing up with epilepsy. We then consulted with expert reference groups and produced this pilot group therapy, and from that we developed the 6-session psychosocial intervention for epilepsy, or PI, and it was very successful. We did this around the UK, and we found that the more important findings were that everyone improved in terms of their epilepsy knowledge. So the kind of group goes from the first couple of sessions are around much more around epilepsy, knowing about different seizure types, understanding your own epilepsy, how to speak to the care team. And then they progress on to being more standard mental health things, so about CBT and mindfulness and that sort of thing. So 6 2-hour sessions. So everyone's epilepsy knowledge increased. And also at 3 months and 6 months, we found that their knowledge had gone up more and more. So you turn people into kind of self-guided learners. It wasn't just to learn from the course, they just learned how to find out. And also they were much more confident in speaking to other people about their epilepsy. So by the end of the intervention, no one wasn't confident, and most people were very confident. And very high in feasibility, so 94% would recommend it to others. And the sort of benefit from this was we were using the existing care teams. So it was running the centres that would have an epilepsy nurse and a psychologist. So whilst there was maybe about 15 hours of time from those professionals, there was no other costs associated with this trial. So After we saw the NHS England service spec last year, we thought, well, we could do with revising this. So this is part of Anthony's job. So we've retained the kind of course structure and format of the original RCT, but we've updated the content, materials, and used all the feedback from people who've done PI in the meantime. Anthony's created a 120-slide PowerPoint deck to deliver the whole course, and we've updated the manual for the people who deliver PI, and also the workbook for the young people. So these things are all integrated. And we've just made sure, we've also thought about access, so things with neurodiversity. So we've got some different formats for some of the activities that might be more individual focused rather than group based. Anything else to say about the neurodiversity aspect?
I guess the lining up of all the different materials as well means that people can drop in.
Yeah,
it's a lot easier. So if they miss bits.
Yeah. So, and also just thinking about the actual components, we've used more ACT, we've dropped the mindfulness, and we've used more acceptance, commitment, therapy principles, and I'll show you that in a second. Just like this person. So, who's it for then? So, it's for young people with epilepsy, aged 12 to 17, with a diagnosis of epilepsy, and you need to be proficient in the use of language. It's a very kind of language rich milieu. It's not really specified in its current format for people with intellectual disability, really, but we are looking at trying to have a different programme that would be of benefit. We're looking for partners to develop that, just to simplify some of the materials. There's a lot to get through. There's quite a lot of talk content. There's quite a lot of interaction. So I think for people with intellectual disability, we would need to massively simplify. And our colleagues in Edinburgh did simplify the original PI into a kind of ID-friendly version. So we just kind of need to do the same with the new programme. Also, it's probably an exclusion if you've got complex, severe mental health problems. That is actually relatively uncommon in those without significant neurodisability, or if you've got non-epileptic attacks without seizures.
Not working.
Oh,
There's a bit of a delay sometimes, I don't know why.
Okay, good. Right, so what's included then? So there's the PowerPoint slide deck that just contains, slide by slide, the 6 sessions, participant workbooks, and a trainer manual. And at the moment, we're not running this as another RCT. We were quite keen to get moving with this because all these trusts in England had money to spend on something. And so we're running this just as a kind of real world intervention, which we're gathering minimal kind of outcome measures on. But we're in kind of active discussions with our advisors around how we might actually kind of move towards a research-friendly delivery. So these are the 6 sessions. So it starts, as I say, really talking about epilepsy. We've got some lovely animated videos from Epilepsy Action that explain, so they're like talking heads you can click on that talk about different kinds of seizures. Also kind of stories around using alcohol, etc. So there's nice video content embedded. Lots of kind of activities where you're rehearsing, speaking to a doctor or nurse or your psychologist or about having epilepsy, speaking to other people, speaking to friends. Then it's much more around kind of managing, problem solving activities. Should I go to a sleepover? How do I manage my sleep schedule and study, and just actually think about how we live and how we manage a condition. And then, as I say, moving towards the kind of more mental health aspect in the last 2 sessions. So because of time, I'm not going to take you through, on a kind of longer session, we kind of have an example from each session, but we'll just move straight into the kind of mental health stuff. So there's a kind of classic session on CBT principles, where we try to educate people around, the cycles of avoidance and the way that how we think might lead to how we might avoid things or change our behaviour. So a lot of content there. I'm sure this group are very familiar with the CBT model, looking at negative thoughts and how we kind of appraise situations. These are thoughts, not facts, etc. And we just kind of worked examples through so that it kind of really sits with people in terms of their lives and how they would understand this. Okay. And then, you know, so we'll do a formulation that's more kind of anxiety based, about thinking you're not good at speaking to people, feeling anxious or worried with friends. And then one that's more kind of mood based around, you know, how things that might happen that would make us feel down. And then this is the interventionist manual. And so it's kind of color coded. So red is a kind of, this is how to explain the activity. The green puts you to the page in the workbook that the participants have. And also the green is a suggestion of you might introduce the activity like this. So what we're saying is we're quite laissez-faire about this. So this is the kind of guide, but you don't have to be really adherent to it like with the RCT. And then this is what the participants would have in their own worksheet. So there's a lot of integration. And then session 6 is really around sort of more active principles, and again, just trying to work through examples over the 2 hours. You know, things like looking at the threat system, the drive system, the soothe system, or classic ACT approach. So I'm aware of time, so I'm going to breathing. So this is what it looks like. So when people have to get Caldecott Guardian approval, sign copyright forms, and then we send them the materials, the slide pack, the workbook, and the manual. So since July 24, when we launched, we've had, I think it's about 120 now, clinicians attend launch events from about 75 centres. 10 groups already have signed up and are delivering high revised. And as I say, we've got a lot of other groups thinking about this. So the strength of this is that this is a free-to-use intervention that can be used by the existing workforce, RCT-backed intervention, and hopefully if we can have quite wide-scale adoption, even with the feasibility measures that we've got in the pre and post outcomes, we'll still have a data set in the next year or two that, of course, could be used to think about a further large-scale intervention. We've also got interest from the International Bureau Against Epilepsy, because they think this could be an intervention that could be used widely in developing countries as well, who have no mental health support and very poor epilepsy services. So I'll stop there. I think that's 15. And if there's any questions,
Very much. Anyone, any questions?
What do you find being the biggest motivator, biggest challenge for bringing this into practice? Is it the Caldecott, or is it getting through approvals, or where is your biggest, how do we do this faster, how do we roll this out?
Yeah, good question. I mean, the Caldecott thing tends to just be an email, because we've got standard operating procedures from our data guardian, and the Caldecott guardian's like, yep, that works, that's fine. The block is epilepsy nurses. The block is found in, so we think about 60% of the course needs to have an epilepsy nurse in the room. But epilepsy nurses are under such pressure, and there's lots of vacancies, and we do need someone with those competencies. So we've said, you know, we don't need a clinical psychologist per se. They could maybe get a trainee or psychological therapist with the competencies, but you need an epilepsy nurse or a junior doctor. So that's the block at the minute.
Excellent. So it sounds like a really good intervention. Has it been evaluated with regards to mental health outcomes?
So in the RCT, we did include EDI and BAI as outcomes, but actually, even at baseline, no one was scoring really high on those measures. Because as I said, I think for the majority of young people with epilepsy, the mental health issues are anxiety, avoidance, social exclusion. They're not scoring really high on mood measures. So we think there is a mental health component to the intervention, but it's an early intervention. So it's probably not right for people with complex, severe mental health. It's probably not enough intensity there for that.
Yeah. I was just interested in the intervention and some of the challenges that you're talking about. Kids with epilepsy sound really similar to kids with like ADHD and autism.
Yeah.
I wonder, and some of the intervention seems quite general.
Yeah.
Interested in your comments on that.
Yeah, I mean, so I think the mental health stuff's quite generic. I think it's how we work the examples through that make it more specific. But absolutely, this format, you could reprogram it with other conditions. the epilepsy stuff, you could reprogram that with ADHD or autism or any physical health condition. There's a lot of other groups working in chronic disease groups that said, well, do you think we could do this with neuro-oncology kids? Or I think probably, yeah. So I think it's a good model for health service-based staff to offer these early interventions. Again, for these kids who can't get into CAMS because they've not got your classic complex mental health problem.
Thank you very much. I don't think there are any questions online, but thank you very much. Donald, sure. Okay, hopefully there won't be so many pop-ups coming in the way of your patient, but
I don't think anyone will up here now. I think people will just leave now. Stuck with me now. Hi everybody, how you doing? My name's Donald, and my talk is nowhere near as polished and professional as that. Mine is far more just ongoing stuff. You may have observed, or not, as the case of the chair, where I've slightly changed my topic because the previous one is done and away, and this is a far more up-to-date analysis that we're doing, and I think quite an interesting topic. If I'm a boring person. So anyway, my fundamental interest is in how do we get from risk factors to aspects of brain structure and function. So there I am holding a copy of my brain to a cognitive impairment. And here's a copy of my brain as scanned at the fancy ICE facility in Queen Elizabeth. So in 2023, and quite generally, dementia and Alzheimer's disease is a major source of death and disability. So it is a major public health concern, quite obviously. In 2020, and then more recently in 2024, the Lancet Commission, not everyone necessarily will be that familiar with the state of the field in Alzheimer's disease, but essentially the Lancet Commission is this group of prominent researchers and professors and very senior people who came together and identified what they consider to be the main kind of risk factors, the main modifiable risk factors for Alzheimer's disease. And amongst those, you can see things like education, hearing loss, and in particular, for our purposes, high low-density lipoprotein cholesterol, aka bad cholesterol. And these are all things that they estimate to be modifiable, which can lower risk of Alzheimer's disease in the general population. So my main interest, going back to my PhD, is what's called apolipoprotein E genotype. Now, ApoE is the, after increasing age, it is the greatest risk factor for Alzheimer's disease, for late onset common Alzheimer's disease. So it's the greatest risk factor that we're aware of, and it's obviously not modifiable. Now, part of the problem with ApoE is that it is very what's called pleiotropic, that is, it influences a wide range of different functions in the body. And it does that principally through its main function of lipid metabolism. And amongst that includes the accelerated accumulation and poorer clearance of amyloid beta, which you might be familiar with regard to the amyloid cascade hypothesis, which is this kind of dominant theory of Alzheimer's disease. Not the only, but kind of the dominant one. Everybody has two ApoE alleles. You either have E2, which is potentially protective, E3, which is risk neutral, or you have E4, which is risk. So these are quite common mutations. So within the room, we will probably have someone who has one copy of E4, maybe someone's got two copies of E4. They're all quite common in the general population. Where someone with two copies of E4 is in the worst condition for risk of Alzheimer's disease. So if you possess one copy of ApoE E4 genotype, which is in about 23% of the general population, so about 1 in 4, your risk of Alzheimer's disease goes up by about 3 times. If you have two copies of ApoE E4, which is in about 2 to 3% of the population, your risk of Alzheimer's disease goes up 15 times. We've known this for a very long time. And not only does it increase risk of Alzheimer's disease full stop, it also accelerates the age of onset. So not only do you have much higher risk of Alzheimer's disease, but the risk of its onset and your diagnosis is also much accelerated too. So what you can see in this figure is the age of onset of people with Alzheimer's disease. And you can see that it's much, much earlier in people with 2 copies of ApoE4. If you came specifically for my original topic title, and I know I'm speaking to nobody there, I find it interesting. Then our analysis in the UK Biobank with the original title showed that we didn't actually see this quite in the stepwise way that you see here, but we do see a homozygous effect in UK Biobank. And we think that probably reflects that this is a study of onset, whereas Biobank, their phenotype is age at diagnosis, which is a slightly kind of harder phenotype. That's by the by. So what we were fundamentally interested in was, if we know that ApoE4 is this common, quite relatively highly penetrant genetic risk factor for Alzheimer's disease, does it associate with circulating blood biomarkers in perfectly healthy, happy people? And the answer was yes. We looked at a wide variety of biomarkers, which are common things that doctors might seek out. So things like HbA1c, which are relevant to diabetes, cholesterols, apolipoproteins, markers of inflammation like CRP. And we looked at these according to ApoE genotype. So first of all, do people with risk genotype in ApoE have differences in cross-sectionally in terms of things like cholesterols, biomarkers to do with cardiometabolic health, inflammation, that kind of thing? And the answer was, generally speaking, that yes. And the reason this was interesting, we thought, was it's potentially giving insight into what's different about people potentially decades before they develop Alzheimer's disease. And we published this 3 or 4 years ago. And like I say, what we found was that in non-demented people, about 500,000 people with no evidence of dementia, people with ApoE4 risk genotype show differences primarily in things to do with cardiometabolic health and really predominantly in lipids. So here, for example, if someone has 1 copy of E4 genotype, they had about a 0.15 standard deviation difference per allele in low-density lipoprotein cholesterol, which is the bad cholesterol. And if you had protective genotype, it was in the opposite direction, which is kind of what you'd expect. So what we were saying there is that at least some of the conferred risk from ApoE4 genotype onto Alzheimer's disease might be via these lifelong differences in biomarkers. But what we thought was interesting is that this was a cross-sectional snapshot in time. So this was 500,000 people with various biomarkers. And we show these differences between genetics and these biomarkers, but a problem with any cross-sectional thing is it's always a snapshot. People will have different trajectories as they get older. And you see that with ApoE, where you may not see an association with, say, cognitive health cross-sectionally, but that's because people age at different rates. And so a snapshot is always lacking that bit of information of longitudinal decline. So it may be that ApoE's effects on the body are less about cross-sectional differences and more about the rates at which we age. So UK Biobank, if you're not familiar, is a cohort study of around about 500,000 people who about 20 years ago came to one of 22 assessment centres and provided a huge amount of information, whether that's genetics, psychological, physical phenotyping. And what we're looking at today is the sample of about 20,000 people who came back 5 years later and repeated the whole thing virtually verbatim. So here, you can see the 2006 to 2010 baseline. And then you can see here, about 2012, about 5 or 6 years later, 20,000 people came back and repeated all the biomarkers, all the cognitive tests, all the psychological stuff, all the physical stuff. So you've got 20,000 people with complete longitudinal data. How long have we got left?
About 4 minutes.
Okay. We'll get on with it. So what did we do? We were interested in, we know that ApoE associates with cross-sectional differences in blood biomarkers. Does it associate with change in these biomarkers? So we measured change by controlling for time 1 values at time 2, which gave us a kind of a change score. And we adjusted for things like baseline deprivation, cardiometabolic conditions, certain slightly boring genetic things, age and sex. And we looked at whether or not people with possession of ApoE4 showed differences in the rates at which their cholesterol accumulated across 5 years. 4.33 years. But what we found was, first of all, we've 99.9% replicated the associations that we found a few years ago, cross-sectionally. I find this quite funny, that in the repeat sample, we see almost exactly the same betas with 17,000 people as we did with 500,000. So we didn't really need to bother with the vast majority of this cohort to find this in the first place, but anyway, I find that quite funny. But the most interesting thing is that these first two are cross-sectional associations, and the third association is the change. And what that shows is that people with ApoE4 had significantly increased accumulation of LDL across 5 years. This was exactly the same with apolipoprotein B, and again with total cholesterol. So what does this mean? It means that, first of all, we found generally consistent associations between ApoE, E4 genotype and worse lipid biomarkers cross-sectionally, but we knew that, but also with accumulation and change across 5 years. This means that at least some of ApoE's association with blood biomarkers might not be just because of differences from birth, but actually how these things accumulate across the lifespan. This also suggests that if you think back to the Lancet figure that I showed at the beginning, a substantial amount of the estimated contribution of Alzheimer's disease seems to be low-density lipoprotein cholesterol, and this implies that at least some of that contribution probably comes from ApoE. There are, of course, very well-known limitations about UK Biobank, so we've known for a long time that it's a relatively, it's not a diverse population. It is 90% white, relatively educated British people. That's quite important because we have illustrated subsequently with UK Biobank that if you only look at a relatively biased, overly healthy population, you're not really getting, you're underestimating the magnitude of effect, which is probably the case in the real world. So what are the next steps? The next steps of the study are to widen it to a wider variety of biomarkers, so things like urine biomarkers, HbA1c, glucose, that kind of thing. Validate it with other longitudinal approaches. So we used one measure of change across time, but there are other statistical ways to do that. And also investigate the role of protective ApoE2 genotype on these biomarkers. So do people with ApoE2 protective Alzheimer's disease genotypes, do they show no change at all? Or do they actually get better across time? What's the take-home message from this talk? ApoE4 outright association with cardiometabolic blood biomarkers may be partly due to accelerated lifelong change rather than outright levels from birth. And this was part of Toby's MPH project from last year, which we're going to be taking forward. So a lot of the work here is thanks to Toby. Right. I wonder how left. Hang on time. Really? Yeah, I don't really could have taken more time if you needed, but in dance. Any questions yet, Jocelyn?
Do you notice changes in medication uses for your statins and your regulators?
Between the 2 points. Yeah, so that's something that we'll definitely look at next, is to what extent can this be attributed to the onset of things like statins and different medications across time. Yeah, but it'll be tricky because a lot of the variables in biobank are just, they do the phenotyping baseline and they do the phenotyping again when they came back in. So it'll be difficult to kind of say that, okay, it was halfway through the longitudinal assessment. But yeah, it's definitely a very valid point of to what extent is this due to changes in medication. But that would be still interesting if it's because of, changes in medication. And then, well, why is that the case? Is why are people with ApoE4 more likely to need medication?
Do we know anything about whether the association between ApoE and symptoms can be attenuated by some of those factors and that kind of thing? Presumably that's a question.
Yeah, well, it's very interesting where that's kind of what I was vaguely getting at, that some of the ApoE association might be attenuated if you could address things like the LDL cholesterol there. So maybe it's the case that if you're at the moment, ApoE4 makes absolutely no difference to people's day-to-day lives. It's not really considered a factor in clinical type stuff. But this is saying that actually it's not just the case that, oh, well, you're ApoE4, there's nothing to do with that. It's saying that if you're ApoE4 and we identify that early, then maybe there are things which are getting worse for you across time, which we should seek to mitigate.
That was a great presentation and a nice data-driven specific illustration of the wider theme of brain health across the lifespan, how by kind of adopting a kind of very proactive approach to the things we do that will make your brain healthier earlier on, mitigate or offset some of the major problems. And there's a roundtable meeting that was put in the Scottish Government and Alzheimer's Stop in December. I'll let you know about it.
Oh, cool.
That'll be a really good way to impact.
Oh, cool. Thank you.
So some years of Berry actually spoke at this meeting last time. He addressed the UN last month on this theme about brain health lifespan, with the bigger picture that everyone's concerned about degeneration in late life. But actually, if we start from a very early place about what we can do to improve, and I think your data kind of nice to show that change across time.
Yeah, and well, thank you. I'm not just agreeing about my talk, but no, there's also a lot of interesting evidence that all these risk factors, these behaviors, so things like smoking and alcohol and risk behaviors, that actually a lot of the genetic influences for Alzheimer's disease influence those things in the first place. So it's not these things are not existing in total isolation. And people with, for example, ApoE4 genotype, but also non-ApoE related genetic risk for Alzheimer's disease are more likely to do things like smoke and drink and all sorts. So it all seems it seems more integrated than I think epidemiology likes to think.
Yeah, absolutely. And there's data almost 20% of live births in the west of Scotland exposed to smoking in utero, and 15% high levels of exposure to alcohol in utero. There's lots of public health, universal education. Be a bit stronger, I think, in terms of brain health across the lifespan.
Yeah, definitely.
So it was just very done on a poll.
Definitely.
There's a couple of questions online. I don't know if you can attempt to address them, or even three of them.
Ratika asks, how early can early intervention be for Alzheimer's disease? Even though changes occur over time, can we promote healthier lifestyles to improve prevention, or is that too simple a message? Thank you. I don't know how early intervention could potentially be for Alzheimer's disease. There's a lot of stuff that all the risk factors for healthier, non-demented cognitive ability are also risk factors for Alzheimer's disease. So things like avoiding smoking, don't drink too much, head injury, pollution, everything that's bad for dementia risk is also bad for the non-demented brain fundamentally. So I would say it's really never too early to thinking about brain health. Desmond, what's the difference between age at onset and age of diagnosis? So age at onset it really depends on the exact study, where a lot of the time these studies are done in America. So onset can be just things like, it really differs by study, but sometimes an age of onset study will have when is the first recorded symptom, when were they first prescribed a medication pertinent to Alzheimer's disease. Sometimes the study is not really about Alzheimer's disease, it's more onset of cognitive impairment, and that might be reported by the participant, whereas diagnosis in Biobank is very literally just diagnosis by an ICD code pertinent to Alzheimer's disease. Martina, thank you. I was wondering whether you're looking to develop this into a diagnostic assay. That's a really interesting one. Martina has asked about could this have a role in diagnostic assay, and I think that's a really profound thing about ApoE, where at the moment, if I have ApoE4, I don't know why I'm addressing the question. Hello, hi, I'm Martina. Hi, everybody. If I have ApoE4, I am not necessarily going to develop Alzheimer's disease. If you get a group of people who have Alzheimer's disease, they very, very probably all have ApoE4. So there is definitely a role for ApoE genotyping in something clinically. I think it's very interesting that decades ago, ApoE genetically just walked up to us and said, hello, we've known about ApoE and dementia risk for decades, and it has absolutely no influence on clinical care or the things that we do. So I think there's definitely a huge amount of, I think there's a huge amount of role for ApoE, and that's really what I'm trying to work out. But no one will fund it, so here we go.
Thank you very much.
Just
Next up for our final presentation, Dr. Desmond Campbell. I've made you a co-host, Dr. Campbell, so I hope you're able to share your screen. Okay. I'll let you introduce yourself, and I don't know if you want a reminder or anything yet, like with 1 minute to go or anything like that, but maybe we'll interrupt if you're going on longer. But we've got a bit of time because Donald was, and everyone has been so much time. But you can see you rather than your slides. I'm not sure if that's on purpose.
Can you see that? Is that okay?
Yes. Yep.
Is it in presentation mode or is it just?
No, not yet.
Okay.
You've got two screens. That might be the issue. You might have to go to an advanced Zoom setting to share the right screen.
Just try that. What about now?
Yeah.
Okay. So, my talk is about the harmful effects of obesity. Do the harmful effects of obesity differ across socioeconomic positions, socioeconomic strata? And it's based using UK Biobank. So obesity contributes to health inequalities because it's a major risk factor for diseases and it's socially patterned. This group, Dietrichson et al., they talked about how this could come about, and they basically have two different mechanisms, differential exposure and differential effect. So differential exposure might be women drink less alcohol than men, and therefore would have likely to have less effects of alcohol, harmful effects of alcohol than men. Differential effect might be, well, the alcohol paradox is an sort of example of that, where the rich drink more than the poor, but they seem to have less harmful side effects of that than the poor. So it seems like the harmful effects of drinking hit the less well-off more. And we're just going to sort of see investigate whether the harmful effects of obesity, whether they differ across socioeconomic position. So to do this, we did survival analysis using UK Biobank and linked hospital records, diagnosis basically, and mortality records. And we looked at 8 disorders where obesity is strongly implicated. Basically, we just picked these, we just got some doctors to, think about which disorders they thought were caused by, causally, not just associated, caused by obesity. So basically the first 4 are, well, they think it's absolutely definite that obesity causes them. And the next 4, they think it's very, very likely that it causes them. We wanted to, our measure of our exposure basically is adiposity, like how fat people are. And we measured it in the sort of usual way of categorizing BMI in the usual thresholds. And then we want to see how the effect of that differs across SEP, socioeconomic position. And we basically, we have 4 different measures of SEP available: Townsend, highest educational attainment, household income, and home ownership. And in our regressions, we adjusted for sex, age, assessment center, and ethnicity. And we made some exclusions. We excluded the underweight because they tend to be unhealthy, but in their own way. That's nothing to do with being overweight. we exclude people who had the disorder at baseline because that's a survival analysis. You start off with, people unaffected. For some of the diseases, alcohol is implicated. And for those, we try to exclude people who had some sort of disorder that was evidence that they had some alcohol problem. And then there's a few other exclusion criteria. So we did a survival analysis. We used just standard Cox proportional hazard survival modeling. So we regressed survival on this variable BMI SEP. So this is basically a categorical variable, and it's just all levels of the combination of the adiposity and SEP measure. So if I have, my adiposity measure was, BMI is either normal, overweight, or obese, 3 levels. And SEP, depended on the SEP measure, but for maximal educational attainment, there'd be 4 levels of that degree down to CSEs. So basically, the 3 by 4, there's 12 different levels in this case of the BMI SEP. And those, because it's categorical, those are free to find. They're not constrained by the other levels. They're free to find their own effect size, completely free to find their own effect size in this model. But even though they're free to find their own effect size in this model, it turns out they're highly patterned. So if you color them by, this is the survival for diabetes, and the SEP measure is highest educational attainment. And as you can see, if you color by adiposity and you arrange them by highest educational attainment, you see it's strongly patterned to that, the more overweight you are, the higher your risk of diabetes, and the worse your education, the higher your rate of diabetes, higher your hazard of diabetes. And that was for, this is for SEP being measured by highest educational attainment. But if I just look at the other, this is for all 4 SEP measures for diabetes. And you can see it's all the same pattern. And it's basically the same pattern across all these diseases, which is it's not that surprising because we picked them to be, for adiposity to overweight to matter. Okay. So using those regression results, we converted those regression results into an equivalent additive hazard model for each of the regressions. And so that would give you, an additive hazard effect for obesity versus, normal weight, low SEP versus high SEP, and for the interaction of those 2 things. The reason why we looked at an additive hazard model is because the additive hazard or risk, if you like, basically is proportional. The costs is proportional to costs and burden. So, it's proportional, basically additive risk equates to extra hospital beds, extra diagnoses, people disabled, etc. And then looking at that, we're then interested in whether is there this interaction so that obesity's effect differs across SEP levels. Here's an example of how the conversion was done. So let's say the top table is the results of a study. So you've got hazard ratios. You've got so for you basically got BMI low and high and SEP low and high. The BMI hazard ratio for the high SEP people is in the top right, it's 2.3. So the additive hazard for that is 2.3 minus 1 is 1.3. And that goes into the bottom table, top right. Basically, you can fill in the cells of the bottom table and you get an equivalent additive model. And as I said, they're equivalent. You can convert from one to the other. They're just different representations of the same results. And what you can see is that the way to interpret the additive model is there's an additive effect for obesity of 1.3, there's an additive effect of SEP of 2.2, and then there's an interaction term. If you have both those, if low SEP and obese, there's an interaction where it's more than the sum of the two additive things, but it's by 2.86. And you can just plot those as different colored bars in a stacked bar plot. And you get these sort of things. So basically from this you can calculate the risk of any particular type of person. And this is for the 8 different diseases we looked at, and it's for, well, in this case, highest educational attainment. So what you can see is that this interaction component is the sort of pink, I've called it orange for some reason, but it's pink bit of the bar. And you can see that for all of these diseases, it's positive and significant, except for pancreatitis, where it's negative, and for urinary stress incontinence, it's not significant. But otherwise, it's a significant component, 10 to 20%, say, in each case for each disease. And that's basically saying there's extra susceptibility for the low SEP people. They're hit harder by obesity. This is the same thing across all SEP measures. It's just the same pattern. Basically, they're different scales, but qualitatively it's the same. You see the same thing. So what are the implications of this? If you could convert 1 million people from obese to normal, who would you pick? Well, you want to get the maximum health improvement. So you're going to pick the people who, with the biggest obesity disease effect. And in my case, that would be the blue and orange, those with the blue and orange, blue and pink bars. So that is basically the low, you would just end up picking low SEP people. So if you can convert 1 million people, you just convert 1 million low SEP people from obese to normal. However, such targeting might be costly or unethical. So you could think of targeting the whole population. You could have something like, say, a sugar tax, and let's say that intervention results in the same obesity reduction across all strata, across the board. Still, you would get the highest disease reduction in the low SEP stratum, and it's for the same reason. They're getting a benefit of that blue and orange bars, and the high SEP people are only getting the benefit of the blue bar. I mean, that is actually, a sugar tax isn't likely to give the same obesity reduction across the population, because different people are more affected by a sugar tax than others. But you get the idea. If you could target the whole population, you still get the biggest effect in the worst hit people. Yes. Right. So there's also some implications for etiology. So if you imagine a sufficient component cause, Rothman's causal pies model of the disease, what do these results imply? Basically, they imply that there's more of those well, there's more Rothman causal, sufficient component causes out there, more prevalent in the low SCP people, where they only need one segment obesity to complete make a sufficient component cause so they get a disease. So the way you can get that is either the unobserved risk factors are more prevalent in that stratum of society, or it could be that those risk factors are co-occurring more frequently in that stratum of society. Okay, so the limitations we have are, well, first of all, there's limitations about UK Biobank. It's wealthier and healthier than the standard UK population, the rest of the UK population. We only did Cox proportional hazard modeling. We didn't attempt to deal with competing risks. We'll probably do a sensitivity analysis to do that. We had some problems with our exclusions, not massively, but some problems with our exclusions in that of people who might have had the disease prior at baseline. And that was because in some cases, people were measured with ICD-9 instead of ICD-10. So we had a mix up over that, as it were. And some of the exclusion criteria for the heavy alcohol use wasn't very successful, unfortunately. But anyway, those are our limitations. Well, we'll try to quantify how big these effects are in the future. And these are the people involved in this study. Thank you.
Thank you very much, Desmond. That was really interesting. Any questions here in the room with Dr. Campbell? And any questions online? Maybe I could kick off with one if that's okay. This relates really strongly to my own work, looking at health behaviours and whether or not there's differential susceptibility across socioeconomic strata for health behaviours, not metabolic factors like obesity, although they're obviously strongly related. And I was wondering, one of the main thoughts or outcomes from my PhD, which on that topic, was about the difference between relative and absolute risks. And I wondered if you had thoughts about, because you use hazard ratios, which is a measure of relative risk, if you'd thought about looking at the absolute differences as well. I know additive models sort of try and tap into that a bit, but I was wondering if you thought of looking at the absolute number of cases, for example, that are different across the socioeconomic strata.
Yes, I think that would be our next, we hope to address that. Like that would be sort of this section here, like trying to look at population attributable fraction and stuff like that to quantify it. Certainly I did present these are additive hazards, as it were, additive hazards, but they are all still relative to the baseline as well. Yeah, but I mean, obviously, you just have to multiply by the sort of prevalence in the population of each of the diseases to convert it into absolute.
Okay.
Yeah.
Very good. I was just thinking from a policy perspective, showing policymakers the numbers of cases that could be prevented by thinking about differential susceptibility and tackling that.
Yeah, I think that we absolutely intend to try and do that with a path, some sort of path measure. Don't know how we're going to do it yet, but yeah.
Anyone else? Any thoughts? I was just wondering as well, if you're planning on looking at mortality outcomes, you're looking at diagnosis of diseases, and why you thought about that as opposed to mortality outcomes.
We, well, in an earlier version, I sort of did it by, I just looked across all ICD-10 outcomes, which I just coarsened by just dropping off the bottom letters or numbers until I got to about 10 or something categories, and didn't see any particular effect. And we reckoned it was basically because because obesity doesn't affect every disease, yeah. So basically, then we just got well, the other people in the study, the doctors said we just have to look at the diseases that are affected by obesity. So that we came up with these 8, and we excluded quite a few. Like we excluded back injury, for instance, because obviously back injury could cause obesity as well as be caused by, yeah. So
Yeah, Jocelyn, we've got a question here.
Very simplistic question. How well recorded is alcohol and alcohol consumption in ICD-10 records and Biobank in general?
it's there's a bunch of ICD-10 diseases which are, you know, they've got an ICD-10 diagnosis. You know, there's quite a lot of them. There's also, and that's what I used to exclude people if they had some sort of ICD-10 alcohol diagnosis that meant they were a heavy drinker, yeah. But there's also available, there's also self-report measures of audit C, and that's only for about 20% of people. And also, but there's also a self-report question of how frequently do you drink, which is everybody does. Everybody answers that question. So that's a pretty good question, but I didn't use that one.
Thank you.
Well, thank you very much to all our 3 speakers. Really interesting talks, and thank you for coming all this way and for presenting. Thank you. If anyone wants to present for future cross-beam seminars, please get in touch. Thanks very much. Thank you very much.